have, whatever the case may be. So this is just a reminder that having reactions is normal, right? Pay attention to what you need in the space. Feel free to take your breaks. If something just feels too real for you in the moment, you can step away, whatever the case may be. It doesn't matter what presentation I'm doing. I invite you always to take care of yourself. Next slide. Okay, so I have a lot of slides for you to kind of walk you through our process over the last year, but I am hoping that when you walk away, you will be able to identify workflows that we have been using for immediate crisis care in our integrated care settings. And then, how we have tried to apply the trauma-informed care model to our clinical practices and workflows, of which I have some examples also embedded in our conversation. Next slide. So the crisis team here at Howard Brown Health, I like to explain us as a toddler. We were infant for a while, but I'm pretty sure we have our feet and we're starting to waddle around and we're starting to make sense of what's working and not working, right? And really, the last year has allowed us that opportunity. We went from a team of myself to a team of 5. So I'll talk a little bit about what that looks like. But our biggest goal, by and large, is to apply trauma-informed care for our patients, right? And as a reminder, really what we're trying to do is decrease any re-traumatization, support resilience with people who are walking into our doors, right? Provide healing and wellness for the person that is in front of us. At the same time, we are, of course, trying to hold historical experiences of discrimination, right? We're a healthcare setting. It exists. We want to hold that. We want to be aware of that. We want to be aware of oppression and how that exists, not only within our setting, in our kind of smaller groups, our communities, our nation, and even globally. And really understand how all of these experiences contribute to how someone shows up in our spaces, right? I think when we can have a conversation about this, I think many of us are trying to do trauma-informed care. Transparently, it's really hard to do with all of the different stressors that are hitting us right at the same time. So our team really tries to hold the intention behind trauma-informed care and provide that experience to the patients that we work with. Next slide, please. Okay. So our inception of the team was, of course, in 2020, right? So the slide in front of you, is by no means an exhaustive list of what was happening at that time, but you can see some of the things that were happening. It's hard to believe, just 2 years ago, right? The images show things like the COVID-19 pandemic, global climate issues that were happening, racial reckonings in our nation, all sorts of other things that were also happening at the same time. A discussion about more suicides by Black Cook County residents that we've ever seen before, increases in folks using substances, increases in overdoses, right? 2020 was, and we continue to see just many things happening all at the same time. The one thing I want to note that I just couldn't find the right image for, but that we were also holding here at Howard Brown Health as a federally qualified health center, and our focus is truly affirming care for the LGBTQ community, is also naming that at least 44 transgender and non-conforming people were fatally shot or killed that year, and the majority were Black or Latinx transgender women, right? I say at least because, as we know, oftentimes this things are misreported or underreported or not reported at all in terms of trying to gather information about people and their identities, right? And you may have similar organizations. Howard Brown Health tends to have people who live, work, and provide services to other peers in community, right? So every time something happened in community, we could feel that personally in our organization, right? So it was a lot that we were holding that was happening all this in 2020, but also things that had accumulated before And as you all have probably seen, many things have happened since 2020. But that gives you an idea of like what was going on, what were we dealing with at the time. Next slide, please. All right. So then, you know, we were looking at, well, what are we hearing from our clients? I'd be interested to hear if you were hearing similar things. Our wait lists for a consult or seeing someone were expanding, right? So we had patients struggling that they needed some immediate assistance now. They can't wait. They have been waiting. They simply just needed something in the moment, right? Psychiatric medication, I know that's been a struggle for a lot of folks, but really truly limited supports to try to help someone get a psychiatric medication, right? And having a hard time trying to figure out where to triage folks so that they could get sooner psychiatric attention. I think many times, depending on our providers, and we have a lot of psychiatry providers compared to other organizations, there was still a wait to see people, right? Because truly, I don't know that you'll ever have enough, even if you're fully staffed, to help everyone with the consult that they need or want, usually urgently, right? Something's not going well. They need some help in the moment. Our doors, we have never had a walk-in service, right? The crisis service team is the first service line that's truly for that purpose. That being said, we have had people historically walking in our doors asking for immediate behavioral health support. Usually a friend, a community member, somebody says, just go to Howard Brown and they'll help you, right? And we were having a hard time triaging those folks in addition to our primary care folks, in addition to all the other folks that we were also servicing here. We had folks walking in with psychosis or delusional thinking, which in and of itself is just a presentation folks have. However, that's oftentimes very stressful for our team to manage when there isn't a point person to help them, help the patient figure out how to access our space and get their needs met. We had patients calling, needing behavioral health support for IPV things that were happening, or other situations. Oftentimes we have patients calling us saying, even in the moment, they're experiencing community violence and they're calling us as opposed to calling other folks. And the last thing that was super relevant and continues to be relevant is oftentimes many of our patients don't feel comfortable reaching out to an outside service because they have a fear of being misgendered or unaffirmed in their prior experiences. So that's what we were hearing from our patients as we were trying to figure out what's working, what's not working. Next slide, please. I don't know if this image strikes you all, but this is what we were hearing from our staff. There's also the little image. I don't know if any of you have seen the little meme that goes around. There's like a dog standing in a fire and he's holding up a sign that says, "It's fine, everything's fine." Those are the two things that I think of when what we were hearing from our staff, right? Just feeling the burden of all of these things happening at the same time, in addition to really just truly wanting to provide the best care for our patients that they could, right? And wanting to affirm that, yeah, this is a really complicated time to be in healthcare. This is a complicated time just to be in community. And how can we try to support you so that you can do the work that you want to do? Next slide, please. So we did do a needs assessment. I kind of gave you what we were pulling from patients, but these were I have two slides here that were from our needs assessment of our medical teams, our case management teams, our support teams here. All of them were asked about 10 questions about what their biggest needs were in terms of immediate mental health needs, because that seemed to be the thing that was the most urgent. So the question you see in front of you is we asked them, what are your team's mental health crisis needs? And then we gave them a list and they could also add in what they wanted. I know you can't see all those responses the best, so I'm going to read them to you. The Survey Monkey doesn't let you copy paste and switch around that stuff. So the first one was none of the above. As you can see, that was the least popular option. The other one was meet with patients who are tearful or in emotional distress, assess ability to stay safe, answer questions about mental health care, help me understand and assess safety needs, meet the patients who drop in and are looking for urgent mental health support, substance use, sexual assault, assess client ability to stay safe from self and others after the appointment is over. And then there was the other one that people could also answer. So some of these, Howard Brown Health has the crisis service. We also have a BHC team, which I think many of your sites might also have, which is an integrated care service team. They're helping with the primary care, right? So we learned two things from this. One, we want to be able to have mental health crisis support available in the moment as needed. Also, we wanted to retrain, again, our system so that they understood how to best get clients, patients over to our behavioral health consultants who could also do integrated care work, right? Because patients who are tearful or in emotional distress aren't always in a crisis. Sometimes they just really are trying to share their experience with the person that's in front of them, right? And we wanted to try to strengthen and build resiliency within our teams so that they didn't feel the urge to have to do an immediate consult with someone, that they felt like they were able to talk with the client, understand what was going on, and then, if appropriate, refer to somebody else. But oftentimes people show up and they've just had a lot going on, and tears are normal. We wanted to normalize that that's also okay. Right, and then we also wanted to get a sense of, because we were subjectively hearing a lot of different things from our teams, right? So oftentimes we would be saying, I'm getting five crises in a day, or whatever the case may be, because in the moment they felt very overwhelmed, even if it was just one person, or one person took, 3 of their 20-minute spots, and then they put that kind of pushed the schedule all the way back, and they had a hard time trying to adjust and recover from having their schedule have an unintended long session, which messed up all the rest of the sessions for everybody else, right? So we asked them how often their team was handling a mental health crisis situation. And this one's a little easier to read, right? And you can see, by and large, most of our folks said multiple times a day they were handling some sort of mental health crisis, followed 2 to 3 times a week, followed by multiple times a day, that feels like a lot. We had actually a lot of people answer this for us, which was exciting. Usually we don't get a whole lot of people to respond to our Survey Monkeys, but I think about 150 people, 180 people answered this survey for us, which is a good chunk of the folks that we asked to respond. And you can see how that varies from for different folks also. And some teams have embedded support in them, like our Empower team, which focuses on sexual assault. Our medical teams do have behavioral health consultants. So we already had that there, and this is kind of what we learned on top of already having some of those embedded supports. All right, next slide. So I'm guessing you will know, oh, hold on, I might have missed a note. Oh yeah, let me pause before I get to this one just to add some more information for you. So we also asked our teams in that survey I was discussing a little bit more about their needs. Just so you all know, I want you to kind of know what they shared with us. Some of the things we recognize were outside of what we could offer. And some of the things were things that we've collaborated with folks about, who some of you might be on this call. So our internal teams also said that they wanted staff available during our operating hours, right? So we had, because of the COVID-19 pandemic, we had gone to some hybrid models. There were some days where behavioral support was not available on site. It was pretty clear that that wasn't working. They wanted crisis workers on site. So our crisis team is fully staffed in our brick and mortar locations. So they are there physically. Most of them wanted the crisis workers to see patients or do consults 24 hours a day, 7 days a week. That was their preference, so that they could always have someone available to them. Let's see, staff also wanted them available with an open schedule. 88% of the respondents said, I want someone to be able to help me in the moment. 37% of our respondents wanted immediate access to psychiatry. And let's see, it was important that they have different ways for patients to connect with crisis. So we have 3 different ways that you can reach us. The phone, we can do a virtual meeting with someone via Zoom. We can also see that person in person. So those are the 3 different ways that you can access us. And most of our folks, 56%, wanted a crisis worker available at each of our locations. That is not possible. We don't have the space to do that. So we have figured out a workflow where we can, I don't have a better word, but like deploy someone to the site where they're needed, and then somebody else kind of helps triage in the background until that person is able to arrive on site. We do have our folks who are in our brick and mortar locations at the sites, both in our kind of north and south regions, at the sites where we see the most folks walking in for needs. So that's where we have stationed them. In terms of the 24-hour, 7 days a week request, we only staff during our hours of operation, which is mostly 9 a.m. to 7 p.m. However, we have been working with many of the folks that are on this call so that we can connect with mobile crisis units after 7 and have our call center folks redirect folks to those units. And then we're working with those units so that we can hear from them if they have an interaction with one of our patients, and we can follow up the next morning. So unable to do staffing of 24 hours a day, 7 days a week, which was also one of their big asks, but doing what we can within the hours of operation. All right, now trauma-informed care. This, of course, I believe talking with the folks who arranged this lovely gathering today is probably something you all recognize. Trauma-informed care is, of course, that approach that recognizes that pervasiveness of trauma, the impact of trauma on survivors, staff, organizations, communities, right? And really wants to incorporate this into every aspect of our culture and service delivery. I think it's just important as we're thinking about trauma-informed care to pause and really think about what that means. That's a lot, right? And really wanting to kind of hold that trauma exists. It exists for many of us. I think the statistic is that at least 70% of us will experience a traumatic incident in our life. As someone who lives in the United States, right? It exists where we have experiences to it. And it's important for us to name, hold, and recognize when we're doing this work. I'm just seeing if I want to add anything else here. I think it's pretty much a duplication. The other kind of component that I just want to speak to, I think most of you understand kind of trauma, is what we also want to be intentional about is also thinking about community violence or witnessing violence, right? And kind of systemic discrimination and what that means for people who walk in our front doors, and not wanting to lose track of those things, not wanting to minimize those things, because oftentimes I think we as a system are asking about individual variables about trauma, thinking maybe about like physical abuse, sexual abuse, but we also want to name and hold community violence and systemic discrimination that has happened. Okay, next slide. So you can stop share if you want. I'm going to share just a clip. It's a short one, but I think it is important as we are going to move into how we kind of do our work here. So let me see here. All right, any of you seen this one before? No, okay, cool.
I can remember working in a juvenile justice program, and I can remember walking on a unit and telling the youngster, hey, happy birthday. Not realizing that when I said happy birthday, it would trigger him. He became so violent and aggressive that we ended up having to restrain him. See, what I didn't know was that 6 years prior, when he was 10 years old, his mother committed suicide. So can any birthday ever be happy for this gentleman? So trauma-informed care is something that we studied, we looked at, and I took that birthday situation and I made it the reason why we created files in every program at this juvenile program so that any staff coming on to the unit could access them and see whether or not their language or what they were doing would re-trigger and re-traumatize a youngster. Again, being informed makes the difference. Now, our kids at this facility had significant behaviors that landed them there, but all traumatized youth are not in facilities. No one is immune to the impact of trauma. And we saw that moments ago in here when we raised our hand. We were just talking about the power of words. Now imagine those words coupled with experiences and what it can do to amplify trauma. Trauma contributes to so many mental health issues, such as substance abuse and also violence. So please understand that it is the words that we use that will re-traumatize or put them on the path to healing. I go back and I look at the happy birthday situation and what I would have done differently. I wouldn't even said happy birthday to him. See, I would have used those words to facilitate the necessary changes to create a safe environment and have better outcomes. And it was what I did afterwards of going and being more educated and trauma-informed.
All right. Thoughts on the clip before I go back to the presentation? Because I can see all your face. Well, see the faces that I can see right now. The biggest thing that I take from that, and we're going to circle back to that, is that words have power and how we've intentionally tried to do some of the things that that speaker was talking about by staffing all of the patients that have some sort of connection to our team and coming up with a plan in order to support them and sharing that plan with the different people that they come in contact with here at Howard Brown. So we're going to circle back to that. We can reshare the PowerPoint if you'd like to. But before we get there, I'm going to take you through a little bit more of how we came to define our team. So in April of 2021, these were the tasks that we were given: define a behavioral health crisis, develop workflows to engage clients, staff the hours of operation, provide education to Howard Brown teams to help them understand trauma, and referral to crisis if appropriate. Next slide. So, question for all of you, the chat. The chat is open. Which one of these is not a crisis? A patient walks into the clinic and is told they can't get their medication today as the PCP is not on site. The patient becomes frustrated and yells in the waiting area. A patient calls into the access center, reports that they are not safe in their home and their partner is physically abusive to them. A patient is in the clinic crying. A client is in a case management appointment, not grounded to reality. What do you think? 1, 2, 3, or 4? I will also leave an opening for another option that you would like to type in, if you could put that in the chat. I love the answers so far. So yeah, can you switch to the next slide? It depends, right? the clips that I gave you could absolutely end up in a crisis, or they could not. What we are thinking about as a crisis is the precipitation of an unpredictable event that threatens the client or patient who's the stakeholder, right? And can also impact us as an organization and our performance in order how we're able to serve them. That's the thing I think about the most is what is happening in the space, how are we attending to the person, and how can we best help them get their needs met today, right? The two things that we try to do is rework our workflows. We're always looking at our workflows, what's working, what's not working, how can we improve something, how can our communication improve? And then the second thing is, of course, mitigating or softening that impact when a crisis does occur, right? And we work closely with many teams here at Howard Brown. The crisis team does not exist by itself. Our safety team, our Empower team, our BHC team, we all work closely to make sure that clients and patients can access the service line that they need. And then crisis averted is kind of what we're going for all the time. I was able to say it twice this morning, so crisis averted feels like it's a good image for what we're trying to do. All right, so what our definition of a crisis is a situation where someone's thoughts, emotions, or behaviors puts them at risk of harming themselves or others. When we discuss this in practice, we give examples such as this would be somebody who has suicidal ideation with plan and or intent, right? Suicidal ideation is a baseline situation that many of our clients experience here. So just having suicidal ideation in and of itself is not a crisis. We need to know some more information, and our team is always triaging to understand what is happening, what are the things we know about the client or patient, and where do we need to get them moved to in order to get them helped. The other situation could be someone's ability to care for their basic needs is not there, right? So in this case, oftentimes we're thinking about someone who might be so depressed that they can't get out of bed, or they're here and it's quite clear that they haven't been able to take care of themselves, might be taking too much or too little medication, depending on what's happening for them. And a behavioral health crisis may also include psychosis or acute substance use. Again, we use may because my team's going to triage and figure out what's going on. Is this baseline? Is the person living with psychosis and they're able to get in and out of appointments, and that's fine. They're, we have some sense of how to help them out. Or is this new? Is this early onset? Is this substance induced? And then in that situation, how can we get them in a place where they feel safe if they're trying to not go back out into community and hang out for a couple hours, or if they want to go to detox? There's lots of different avenues that we explore with folks depending on what is going on for them. Because we recognize that our teams, and I don't know if your teams are the same, but many of our teams will reach out to us and say it's a crisis. And upon further assessment, it's not a crisis. Usually it's something that we're able to triage somewhere else, right? But the person who's working with that person in the moment has some piece of information and they don't know how to make sense of it without the rest of the context, right? So really our team is helping to fill in some more information, help the provider that's with the patient understand what's going on, and make sure they get linked to either the appropriate team internally or to us for further assessment, treatment, and follow-up. So one of the examples that I had here, although more have, when I was making this presentation, it came to mind. I took a call at after 5 o'clock on a Friday, because it was like the last call that came in through the call center. And the patient had shared with our call center that they were in a DV situation and they were fearing that their ex-partner would return to the space that they were in. So when I took the call, upon further assessment, I was able to talk to the patient, and the patient was in no immediate risk in the moment, had safety established where they were. They were just so they were so scared and upset about the situation that when they presented the information, they presented it as if it was still happening, which makes sense, right? Because it was a trauma. It felt like it was still happening for them. So it's not uncommon for us to also get a call, try to figure out what's going on, triage, provide a brief intervention, and then get that person to the team that would be the most helpful for them. We're always trying to meet the client or the team with where we're at. And I don't know that I said it intentionally earlier, but we see our team as having actually two consumers. The first consumer would be the client, patient, community member that we're seeing. The second consumer would be our coworkers and our peers. So we try to hold what's best for the client and for the team member that we're working with in a way to help also be trauma informed and make sure that the team member feels like the situation was taken care of and they understand why in context of what we're doing. So two consumers that our team serves here at Howard Brown. Okay, next slide. So as I mentioned when we were talking earlier, there's always one crisis worker, at least one crisis worker available during Howard Brown's hours of operation. Usually there's much more, but at minimum, you would always have one person here. There is always there's always one person on site, not an on person on site, I apologize, and usually 5 who can triage patients' needs or deploy to the site where needed. We use Ring Central here at Howard Brown. I'm not sure what technology y'all use in your spaces, but we have a public chat that is open that anyone can reach out to. That's called a crisis team. And someone can simply say, hey, crisis team, I have a patient I need to consult about. From there, one of our crisis workers typically responds in 30 to 60 seconds, takes that message offline and consults with that person to figure out what's going on, what information do we have, and we'll decide next steps based off of that information. As I mentioned earlier, communication is absolutely key to our success as a team. I think it's just success to patient encounters in general, but we stay in constant communication with our BHP team, which is the BHC team that I was referring to earlier. We will hand off consults to them that are better suited for integrated care consults, and they will hand off stuff to us that they're like, this is going to take a while. This is not a 20-minute integrated care consult. We need crisis to tap into this. So we're constantly talking in between our teams about what does the patient need and who is the best team to serve that. Next slide. Okay, so some of the things that we also provide. So we have immediate availability. Our team does not have a schedule. We move from patient to patient. There are, as you'll see, there are follow-ups. There are scheduled patients appointments that my team makes, but someone is always available in the moment. We work with each other to make sure we're not double booking patients all at the same time. We provide same-day assessment and intervention. That says for our patients. I might have it at a different point, but we also provide same-day intervention to any community member who walks into our front doors requesting behavioral health services. And we do that because it is of our opinion that if you are walking in our front doors for behavioral health support, something is going on, and we want to be able to help you in the moment, figure out what's happening, and at best get you triaged somewhere, but kind of at worst, help you access a higher level of care if that's what you need. So we have open schedules. Typically, I have a little bit of information that I'm going to share with you. I wish I could have shared a little bit more, but typically you'll see that the crisis team spends anywhere from like a minute for a phone call all the way up to 2 hours with a patient, depending on what is happening in the moment. And sometimes we have ended up seeing the same patient multiple times in a day for up to 6 hours of intervention. We are deployable. We talked about that. We have a couple different resources available to us here at Howard Brown. Our goal is never to send someone to the hospital with an involuntary hospitalization. That is not to say that it doesn't ever happen, but our goal is never that. So if patients are safe, we use Ubers to move them around. We also have contracts with private ambulances to move patients to hospitals if that's what they so choose. So we have different ways to try to move patients to other resources if that's what they need. We also complete follow-up sessions to check in on safety or other immediate needs. They have a couple spots open for long-term therapy. A few of them are facilitating groups. We hope to have more, especially drop-in groups for folks with psychosis, delusional thinking in the future. And we're also trained to write surgery letters for patients needing gender-affirming surgery. here is what some of our workflows look like. I tried to be creative so you weren't looking at just the words, but hopefully you get a sense from the images. So from medical, we use the PHQ-9 in our integrated care settings. From there, that obviously goes to the medical team, the MA and the medical provider meet with the patient and talk about what's going on in terms of their PHQ-9, determine if there is any imminent risk, such as a plan or intent. If that is positive, they would reach out to us on Ring Central for an immediate consult, and we'd walk right over. We would assess, intervene, provide a dispo to the medical team, and then debrief. We're going to talk a little bit more about our debriefing afterwards. Psychiatry and crisis work hand in hand. Here at Howard Brown, I think we have 5 psychiatry providers along with some residents. So we go back and forth, right? You can see that's a little bit cyclical there, where a client shares risk factors, referred to crisis for immediate consult and follow up. After we follow up with them, we're circling back to that psychiatry provider. We'll include our safety plan that we came up with or add to the safety plan that they may have already had, addressing any successes they've had or any barriers, and help facilitate perhaps a higher level of care if that is what is needed for that person. Next slide. A walk-in request. So as I noted earlier, we will see anybody who walks in requesting same-day behavioral health support services. It can be a patient, it can be a community member. We are doing that because that's just what was happening, regardless if we have a workflow for it or not. People just walk in. So we want to be able to see them and have a point of contact for them. That person would check in with our PSR, open a chart if they don't have one. And if that's possible, sometimes people come in a crisis and opening a chart is not the first thing we should be doing. So in that case, the crisis worker just sees the person first and then figures out the information afterwards. The person is referred to the crisis team, again, internally using our Ring Central system. We provide assessment and intervention, referrals are made internally and externally, and then we follow up on whatever safety plan we have established with the person. Our PAC team is our patient access center. So what we've determined with them is that they receive a call, they will reach out to us, and we typically work closer with those folks. They take a lot of calls. I don't know about your PAC centers, but they have a lot of things happening for them. So we tend to stay kind of buddied with them if they're on a call that feels like there's a mental health component to it. If it's appropriate, then we will transfer it to crisis. If not, we will help that PAC center person transfer it to the person that it should go to. The crisis team will follow up from there. And most importantly, what we've learned is that we have to circle back, or that debriefing that I keep discussing, to that PAC member. That helps them understand that the patient's needs were addressed, that there was a plan that they came up with. They don't necessarily have to know all the details, but that they were taken care of, and that it was helpful that they reached out to us. All right, next slide. So here I was trying to find better data for you, but I asked for the data a little late and they gave me an incomplete data set. So I'm giving you what I have. From what you can see, this is June to June. So 25% of our contacts were crisis intervention, that 90839s. 30 minutes or 30% of our contacts were a phone check-in from 1 to 10 minutes. Usually those are, as you can imagine, someone checking in about some sort of something they agreed that they would check in about. 15% were phone check-ins that were 11 to 20 minutes, and then 20% of our encounters were billable therapy codes. 10% were MHAs, which are our mental health assessments, or other non-billable activity. Our provider satisfaction is high. Specifically, our staff really appreciate being able to have one person in place to find when something's urgent. I was in clinic this morning. It was not a crisis, but there was a lot of gratitude that I was able to help the person move to the appropriate team. Clients are thankful for having someone to talk to immediately. Teams report less stress, managing mental health on their own. They feel like they have someone that they can consult with and discuss the patient and get the patient moved to if that is necessary. Next slide. Here's the model that we use when we're working with clients and patients. It is, of course, based on some of those trauma-informed care basics that we think about. So that safety, trustworthiness, choice, collaboration, and empowerment. I encourage my team first to check in with themselves, right? Where are they at? Second, we want to meet people with where they are for the day. Third, we want to help them feel heard and supported. And fourth is ending with a plan. That plan is so important when we're doing our work. Next slide. So first is just that self check-in, inviting my staff to say, what am I feeling right now? What does this patient need, feel, or want? What's going on in the environment? Again, thinking about that kind of what's happening in the system, and how do I respond best, right? So why do we do this? Because patients, clients, team members can unintentionally set something off that is our own stuff happening and isn't a part of what the patient or client is needing in the moment, right? And when it's a crisis, how we initially respond to that person can make a world of difference, right? And it can impact all sorts of things. So we're always checking in with each other, saying, my team does a couple check-ins with each other just to see how they're doing, what supports they need, what their capacities are, and really having that open communication with each other. Next slide. Then we meet that person with where they're at, right? This sounds like, what can I help you with? Trying to make sense of their emotions if they are not able to name it for us by simply saying, you sound frustrated. Am I getting that right? How can I make it a little better for you? What are the things that we can do to help today? And then listening to that response, right? We want to listen to really understand what the client is trying to tell us, right? Sometimes people are really great and verbal stuff is their jam and they can easily tell us what they want. Sometimes it comes out in behaviors, or it comes out in like side asks about what they might need in that moment. So really trying to listen for, what is this patient telling us they need in the moment? Thinking about or asking them, what are things in the environment that make it harder for them? So many of our clients or patients who walk into our site are in, I don't know, it's kind of like a fishbowl where a lot of people are moving around, right? And that environment tends to stimulate a lot of things for folks. So if they need that, we move them to a room where it's just them and the worker, less stimulation, less things to think about. Okay, next slide. And then making sure that they feel heard and supported, right? We repeat as much as we can what their words are with us, so that we can understand what they're saying and what they need. Ask if that is what they're hoping to get the help with, right? Clarifying and supporting their statements. We do a lot of support, a lot of validating, a lot of normalizing, a lot of supporting, and then also kind of moving into problem solving and action planning for them. Next slide. And then ending with that plan, right? Thanking the person for coming. That's one of the biggest things we can do for the folks that we work with, is thank them for coming in, thank them for coming to us of all the places that they could go and trying to figure this out. And then I'm, talking about, I'm here to help. Here's what I can do. Here's what I can't do. Making sure they understand the limits of our roles. Also being pretty clear that we're crisis workers. And one of the things that we're mandated to do is our mandated reporting, right? Making sure people know about that up front. And in any way we can, kind of reinforcing what we're going to do next, what we're going to do after this contact with the person is over. Next slide. So I don't have an example here because, again, we didn't have a great usable example, but one of the things that I wanted to share with all of you in a way of planning and making plans is, one, we do have crisis response plans, which many of you probably have in your electronic medical records. So we will use those with clients. But for the clients that are having a harder time navigating our spaces, the team will call together a care team meeting and we will work on a transformational plan. Now, I don't know what your sites may use as kind of similar language, or other language might be a behavioral contract, but a way to understand what is happening for the client or the patient, what are some of the triggers, What are some of the reactions that we can expect? As we were thinking about that clip we saw, what words should we be using, not using? How can we be intentional about how we interact with this person so that they can be successful in managing the space, right? So that transformational plan comes together with, excuse me, our treatment teams. Usually that's a medical provider, it could be a nurse, could be our safety, could be a PSR that often works with that person, a crisis worker, maybe a therapist or a psychiatrist. Usually it's more than 5 people. It's wonderful to have so many people, but usually it's 5 people. We come up with a transformational plan that usually outlines the things that we also expect from the client and patient, but also what they can expect from us, because so many times clients are getting frustrated because in our system, somebody has done something for them that otherwise wouldn't have happened. Like someone got a refill from a provider who was on call because they were just going through and refilling things, and then they can't get the refill again. And now they're upset and anxious and don't understand why they could get a refill one time, but they can't get a refill another time, right? So many times we also have to think about what is our role? How did we maybe not keep a boundary once? How did we, fit this person in, but we can't keep doing that? So how do we hold ourselves responsible? And we write that out so that the client or patient can see it. It's then staffed with the client or patient. They can look at it. They can, if they agree or don't agree with something, they can make changes. And then we sign it and we work from there, and it's shared with all the teams that work with the person. So trying to be intentional about language, trying to be intentional about boundaries, and what works for the person, and communicating about that as a small team that helps treat that client or patient in our space. Next slide. So just a question for you all to chew on. I'm sure that's why you're here, is thinking about trauma-informed care in your roles. And then, lastly, for the last slide, well, I guess there's 2 slides left. One is a question, but thinking about those barriers, right? So we by no means are perfect here. Our environment can be very chaotic, depending on what is going on. You could have 2 lines out our doors for primary care and for walk-in health, right? There's just lots of people coming in and out of our space. Some people are loud, some people are quiet, some people are playing music. So it's thinking about the environment in which you're at, right? And what are some of the barriers to helping people feel like they're safe in that environment? Thinking about the way maybe a peer has had an interaction with someone, whether that was positive or negative, and how that sets an expectancy for the next interaction here, right? Thinking about how that person's coping, one person's coping style might be another person's trigger, right? That's, I think, what makes this conversation great. And I'm sad we couldn't have more of a conversation, because so much of this is what we're trying to figure out. This client really needs a safe, quiet spot, but this person really likes their music and wants to listen to their music. So how do we accommodate different styles in our space? And, some barriers can also be positives. So just different things to think about as you're thinking about what does trauma-informed care look like at your organization. And I think the next slide is just questions or comments, and I think I did pretty good with time. Questions or comments? There are 75 of you here. Oh, come on. Anybody have a question? I didn't notice we went from 30 to 75. If any of you, I'm going to drop my email here. If any of you want to reach out or have patients or clients